I have nothing to disclose. Hello, my name is Gmerice Hammond. I am currently a research fellow in the Cardiovascular Division at Washington University in St. Louis. Thank you for the opportunity to present my work. Today, I will share with you our study entitled Socially Disadvantaged Medicare Beneficiaries Had Worse One-Year Clinical Outcomes, but Lower Total Annual Costs of Care. Health systems are increasingly relying on algorithms and risk prediction models to identify high-risk patients in need of interventions and services, as Medicare and private payers are moving away from fee-for-service and towards value-based payments. Many of these widely used models are built with costs as their primary outcome, with the idea that high-cost patients are the high-risk patients. However, there's evidence that these widely applied algorithms and models exhibit significant racial bias. A recent study by Boback et al. Showed that due to unequal access to care, despite having lower projected costs of care, Black patients were considerably sicker than white patients at any given risk score. This paradoxical relationship between cost and clinical risk among racial minorities is a significant concern and poses a threat to equity in the distribution of interventions and services and may be contributing to worsening inequities in outcomes. If these models systematically underpredict risk in minorities, the use of such models in clinical practice could further widen racial and ethnic disparities because high-risk minority patients may not receive needed interventions and services at the appropriate rates. One reason these models may fail minorities is that they fail to account for social risk, also known as the social determinants of health, which are more prevalent among minorities and are also major drivers of health outcomes. Prior studies examining this have had notable limitations, including Obermeyer's study, which was a single center study of relatively younger patients and was conducted in those privately insured. We set out to examine this in a large nationally representative sample of older US adults with a high burden of comorbid conditions. As such, our study had the following three objectives: to determine, first, whether racial and ethnic minority Medicare beneficiaries had disproportionately low predicted costs compared to their clinical outcomes. Second, if current risk prediction models' accuracy varies by race, and if so, whether the addition of a robust panel of social determinant factors could improve model accuracy. This was a retrospective observational study of participants in the Medicare Current Beneficiary Survey. The MCBS is a continuous in-person national survey that is representative of the US Medicare population, with data linked to respondents' fee-for-service Medicare claims and administrative data from the years 2016 through the follow-up year 2017. Logistic and linear regressions were used to determine the relationship between race, ethnicity, and the following four primary outcomes: annual cost of care, all-cause hospitalization, cardiovascular hospitalization, and death. We then estimated four sets of multivariable regression models for each outcome and measured observed to expected event ratios under the following four modeling scenarios. Model 1 adjusted for age and gender. Model 2 included that adjustment plus a comorbidity adjustment. Model 3 included both age, gender, and the comorbidity adjustment, and also a robust panel of social determinant factors. And Model 4 corrected for social determinant factors alone. I want to make note here that the comorbidity adjustment that we chose is a model that has been used by CMS to predict risk based on cost, similar to models currently widely used and models that CMS uses to assess quality and outcomes. So as this is most relevant to our objectives and had the greatest relevance to policy. This table shows the baseline characteristics of participants by race. A total of 3,614 participants were included in our study. Our sample was 44% male and 11% Black or Hispanic. Compared to white beneficiaries, Black and Hispanic beneficiaries were younger and were nearly 3 times as likely to be dually enrolled in Medicaid compared to whites. Black and Hispanic beneficiaries had a higher prevalence rate of comorbidities such as hypertension. They had 15% higher rates of obesity and over 10% higher rates of diabetes, nearly double the rate of renal insufficiency compared to whites, and also had higher rates of heart failure. This table shows the prevalence of social risk factors by race. Overall, the burden of social risk was high among beneficiaries. However, minority beneficiaries carried a disproportionately high burden of social risk factors, with marked differences across all variables assessed. Compared to 38% of white beneficiaries, 72% of Black or Hispanic beneficiaries were more likely to have an income less than $25,000 a year. Over a third of Blacks or Hispanics had no high school or college education compared to 13% of whites. And just under half of Black or Hispanic beneficiaries reported living at less than 100% below the poverty line compared to 13% of whites. Nearly a third of Black beneficiaries reported financial strain compared to 9% among whites. 69% of Blacks or Hispanics reported lack of social support compared to 50% of whites. These figures show the unadjusted rates of outcomes stratified by race. Prior to risk adjustment compared to whites, Blacks or Hispanic beneficiaries had higher rates of all-cause hospitalization and cardiovascular hospitalization. Prior to risk adjustment compared to whites, Blacks and Hispanic beneficiaries had similar rates of death and no significant differences in annual costs. This table shows fully adjusted differences in costs and clinical outcomes. Among racial and ethnic minorities, adverse clinical outcomes were inversely related to cost. After multivariable adjustment, Blacks and Hispanics had higher rates of cardiovascular hospitalization, but similar rates of annual costs compared to whites. This pattern of similar annual costs, despite higher rates of adverse clinical outcomes, was also observed for several socially high risk and disadvantaged subgroups, including those who had no high school or college education, those who reported living at less than 100% below the poverty level, and those who reported financial strain. We then went on to explore the observed to expected ratios adjusted sequentially under the 4 predetermined risk models. This figure shows observed to expected ratios of all 4 outcomes stratified by race after adjustment for age and gender, which is model 1. On the y-axis, the figure shows the outcomes, and on the x-axis, the figure shows the observed to expected ratios. After age and gender adjustment alone, O to E for all outcomes showed good agreement between observed and expected outcomes among whites, with the exception of cardiovascular hospitalizations, which were overpredicted by 11%. In contrast, among Blacks and Hispanics, adjusting for age and gender underpredicted all-cause hospitalization by 54%, cardiovascular hospitalization by nearly double, so over 200%, with an O to E of 2.18, and underpredicted cost by 21%. After the addition of comorbidities to the model, you can see that among whites, good agreement was found across all 4 outcomes without significant change. And for Blacks and Hispanics, including comorbidities, reduced the O to E ratios near 1 for total cost, but still significantly underpredicted all-cause and cardiovascular hospitalizations, which were underpredicted by 20% and 70% respectively. As we advance to Model 3, Model 3 included the addition of social risk factors. With the addition of social risk factors, you can see that for whites, they continue to have excellent agreement between observed and expected ratios across all 4 outcomes. And finally, after the addition of social risk, similarly among Blacks and Hispanics, O to E ratios for all events were brought near to 1. This is the model that showed all 4 outcomes adjusted for social risk alone. The model adjusting for social risk alone was the model with the best fit, with O to E's of near or equal to 1 for all outcomes in both whites and Blacks. So to summarize the data in tabular form, this table shows O to E ratios for all outcomes stratified by race. Remarkably, the social determinants of health alone model predicts as well or better than all other models considered. In summary, the key findings from this study are the following. First, we demonstrated that there was a paradoxical relationship between clinical outcomes and costs among racial and ethnic minorities in a nationally representative population of older adults. Second, current risk prediction models performed better for whites than for racial and ethnic minorities across a range of cost and clinical outcomes. And third, these data suggest that the addition of social risk to risk models may provide an opportunity to improve the performance of these models for everyone. There are several limitations that are important to note. First, predictor variables were collected via survey, which makes the data vulnerable to certain biases such as recall bias, response bias, and question order bias. Secondly, socially disadvantaged patients may have had lower health literacy, which may limit the accuracy of reporting of comorbid conditions or other variables for these groups. And third, Although we chose variables based on previous studies of social determinants of health, this specific panel of social determinants has not been previously validated. So as we shift from fee-for-service to value-based payment models, healthcare systems and hospitals will need to find ways to mitigate the impact of social risk on the bottom line. If models fail to account for the potential distortion in cost models related to unequal access to care, interventions based on high-cost status may be inappropriately targeted for optimal effect and may systematically under-enroll racial and ethnic minorities. Understanding how social determinants of health can be added to these models and how that impacts risk prediction for racial and ethnic minorities could allow health systems and clinicians to more accurately identify high-risk groups for targeting interventions and avoid exacerbating disparities in care. Future studies will be required to determine the efficacy of modifying treatment based on reclassification or risk using these social determinants data. I'd like to thank members of our research team, my co-authors, and my mentor, Karen Joint-Maddox. Thank you for your attention.
Hi, I'm Vibhu, and I'll be talking on the geographic inequalities in cardiovascular mortality and the impact of public health initiatives. Neither me nor any of my co-authors have anything to disclose. Geographic disparities in cardiovascular and stroke mortality in the US were first recognized nearly 50 years ago. This led to the recognition of the stroke belt as defined by the NHLBI as a cluster of states with disproportionately high rates of mortality due to stroke. This led to public health initiatives led by the NHLBI, the NINDS, and various state and local organizations over the last 3 decades. The impact of these national and local enterprises over the last 3 decades is not known. There's limited data on the contemporary cardiovascular mortality trends in the stroke belt in comparison to the rest of the US. There is limited understanding of how these trends pan out in the future. Based on these, we sought to evaluate the trends in the mortality due to cardiovascular disease, ischemic heart disease, stroke, and heart failure in the stroke belt in comparison to the rest of the US from 1999 to 2018. We evaluated these trends through the subgroups of age, sex, race, and urbanization. We also forecast these trends of CV mortality in the stroke belt and the non-stroke belt region till 2025. The mortality data was derived from the CDC Wonder database. The population data was derived from the US Census Bureau. The study period was from January 1, 1999 through 2018, evaluating all American residents during this period. It was a retrospective cross-sectional analysis of the mortality data derived from the death certificates. All deaths after 99 have been coded using ICD-10 codes by the NCHS you see on the screen. We use age standardization as per the 2000 US Census population proportion, and mortality estimates were represented as age-adjusted mortality rates per 100,000 persons. And over here on the right, you can see the stroke belt region, which is defined by NHLBI. We also did sensitivity analysis using the NINDS definition, which has 8 states and excludes Indiana, Kentucky, and Virginia. We use the NCI's joint point regression program for the analysis, which uses a piecewise linear regression approach to find the ideal fit of the trend by using either a single straight line or multiple linear segments intersecting at various inflection points or knots. The number and location of these knots are chosen by the algorithm to create a parsimonious model which provides a good weighted least squared fit to the data. And the absolute and relative percentage changes in the AMR was calculated for both the regions. We use age period cohort methods by using the observed CV mortality during 99 through 2018 to project and forecast the mortality trends in the 2019 to 2025 period. So the APC model basically fits a Poisson, quasi-Poisson log linear model on the Lexis diagram of the observed rates, simultaneously estimating the parameters that quantify the variations by observed rates, like by age, by period, and cohort, and being the year of birth. These mortality into the future periods have 3 multiplicative factors, first being the longitudinal mortality rate for the reference birth cohort, second, the rate ratio relative to this cohort, and an age invariant period adjustment. We also estimated counterfactual rate projections to evaluate the impact of these of a hypothetical large-scale public health intervention to bridge the gap between the 2 regions. Diving into the results, we see here is a multi-panel figure illustrating a decline in CV mortality in both the regions with a stagnation and decline in the recent years since 2010. Notwithstanding this decline, the CV mortality was consistently higher in the stroke belt in comparison to the non-stroke belt. Interestingly, IHD mortality, which has shown a consistent decline, there was a lack of difference in mortality between the regions. The stroke mortality declined till around 2010, followed by a flattening in the mortality since then. However, it was much higher in the stroke belt. The gap remained consistent, and the heart failure mortality had a was essentially stable, but showed a remarkable budding inflection for increase nearly at the start of the last decade. So the relative gap in the CV mortality we see over here was around 11% in 99 for CV mortality and 16% in 2018. The relative gap in stroke mortality was 24% in 99 and 21% in 2018. And for heart failure, it was an enormous 63% in 99, and it was still 56% in 2018. And there was minor relative difference in the IHD mortality. Over here, we see the absolute difference in the CV mortality. In the last 20 years, there's been a modest decline in absolute difference of nearly around 7 deaths per 100,000. So if you see the red bars, it's all towards the left. So the difference has constantly been more in the stroke belt. There has been a small change in the absolute difference, which was seen in both the stroke and the heart failure mortality. And IHD mortality difference seems to be reversing in the direction of difference. These figures over here illustrate the trends and gap in mortality across gender. So the AAMR was higher in males in both the regions. The mortality gap tracks well in the subgroups of sex, with both males and females of the stroke belt doing much worse than their counterparts in the non-stroke belt region. Over here, we see the trend and gap in mortality across race. It is frequently presumed that race might be driving the mortality in the stroke belt region, but what we see over here is that that CV mortality is consistently higher across the subgroups of race for those living in the stroke belt. So while blacks generally have a poor AAMR, but those living in the stroke belt are doing much worse. Similarly, whites in the stroke belt are doing much worse than their counterparts in the non-stroke belt. Over here, we see the trends and gap in mortality stratified by urbanization status. So the non-metro region of the stroke belt is doing the worst out of the four. I'd like to draw your attention to panel B, where we see there's a large gap in the metro and non-metro regions of the stroke belt. If you see the blue and the yellow lines, and we see that the metro region of the stroke belt kind to be doing similar, if not better than those in the non-stroke belt. So that might be a reason why IHD mortality is similar. We saw that overall it was similar. These are some very important worrisome set of results for CV mortality trends stratified by age. The relative mortality gap in CV mortality between the regions is most predominant in the younger and middle-aged adults. So this is contrary to the popular belief that an older population substrate is driving the mortality gap. So we believe that the CV's risk factors start to set in very early in the stroke belt and manifest very early as well. And similar to the pattern seen over here, we saw the same pattern in stroke, heart failure, and ISD mortality, the data for which is not shown right now. We also did a sensitivity analysis using the NINDS 8-state definition, which showed identical results. We also evaluated stroke mortality by etiology, and is similar to IHD. Ischemic stroke mortality rates were similar between the regions. It seems that the hemorrhagic stroke and unclassified stroke are driving the higher stroke mortality in the stroke belt. Here are the results of the projections. So the observed CV mortality trend in the two regions is likely to continue till 2025 with a likely trend for increase in the mortality estimates. We'll have to prevent the CV mortality in the stroke belt by 5% per annum from now till 2025 for us to bridge the gap, which translates to an estimated 101,953 additional cardiovascular deaths to be prevented in the stroke belt region from now till 2025 for us to bridge the gap. There are several limitations of these data, such as there is lack of data on the birth, the duration of living in the geographic area, the comorbidity burden, and the migration status. There is limitation due to the subjective ascertainment of this cause of death, and there's potential misclassification due to the use of ICD codes. We cannot discern if these trends that we are seeing is due to an increased incidence of CV disease or reported case fatality. There are several limitations of projection estimates, as we all know, and projection estimates may be affected by real-world perturbations like COVID-19. So in conclusion, there has been a decline in CV mortality in both stroke belt and non-stroke belt. The AMR difference has declined by a modest 7 deaths per 100,000 persons, and the CV mortality was 16% higher in the stroke belt in 2018 as well. This is consistent across the subgroups of race, sex, and urbanization status. The CV mortality among younger adults in the stroke belt is rising, and geographic disparity is greatest among younger adults. So we need to strengthen our efforts to be tailored specifically to young adults, such as screening for childhood obesity, hypertension, diabetes, and hyperlipidemia. The gap in mortality that we see in the two regions is going to persist into 2025. We need to prevent an additional 101,950 additional cardiovascular deaths in the stroke belt region between now and 2025 to bridge the gap in CV mortality between the two regions. What we have done for the last 2 decades has not worked, and we are still there where we were 20 years ago. A radical overhaul is needed to ameliorate these geographic disparities. We need to look at novel approaches to ameliorate these long-standing geographic inequities. Here is a take-home slide for all our Twitterati listeners. So in general, we are not doing well, and we need an overhaul of our approach towards managing cardiovascular mortality in the stroke belt. I want to take this opportunity to thank my wonderful mentors, Dr. Pankaj Arora, Dr. Garima Arora, Dr. Anna Best, Dr. Thomas Wang, and my wonderful investigator team, without whom I could not have done this enormous task of completing. Thank you.
Hi, I'm Boback Ziaeian. I'm a general cardiologist, outcomes researcher, and these are my disclosures. The project I'm discussing was funded by the American Heart Association Scientist Development Grant. I'm funded for my research by the American Heart Association and NIH, and I'm an employee of UCLA David Geffen School of Medicine and the VA Greater Los Angeles. And I do have a side job where I tweet monthly or semi-monthly for circulation, cardiovascular quality and outcomes. So really appreciate the QCOR 2020 Council selecting my abstract to be one of the finalists for the Young Investigator Awards. And I'm really thrilled to discuss this project, which is titled National Surveillance of Stroke Quality of Care and Outcomes Using Post-stratification Survey Weights on the Get With the Guidelines Stroke Registry. So just to start with the premise of this issue that we're trying to tackle. So when we think about the US and how we understand disease and outcomes and surveillance, it's always shocking to me how poor the epidemiologic data is in our country. And part of the problem is just how fractured our electronic health records and health systems are. And so we've had to come up with various solutions that are sort of inadequate for how you monitor disease in a population. I think that's no more evident today than it was in the past with the current pandemic about how difficult it is to get reliable information just on counts of cases, counts of testing, counts of deaths. All of this sort of goes back to just how decentralized our data systems are. We're not like a lot of the Scandinavian countries, or even the NHS still has some issues with fractured information systems, but they're much more readily able to pool their populations and quantify sort of disease burden accurately, and variations in care, et cetera. So the problem that I'm stating is that the US lacks an adequate surveillance system for acute and chronic diseases. And the idea for this was how do we modify our existing data registries to be nationally representative? And there's two approaches that you can do. So for any skewed, you have a skewed sample, ideally you want to randomly sample a population for whatever epidemiologic question you have. But when you don't have a random sample and you don't have that infrastructure for either collecting all cases or an appropriate proportional random sample of the population, the general methods we do to describe the population of interest after the fact are post-stratification weights. It's a survey methodology. And so raking procedures are one method for doing that. And they've been around since the 50s, very early statistical theory and ideas about how you go about and adjusting a skewed survey to represent the population of interest. And then, in the last 5 or so years, there's actually been work on more advanced methods using Bayesian interpolation. And so those are basically the two methods that I'll be describing throughout the talk. And so I'd just like to state, where did this idea come from? This was a 3-year project, and the inspiration actually came shortly after the 2016 presidential election. I'd been following Nate Silver and 538, and really interested in how different newspapers and how different modelers were trying to predict the election. And as we all know, the general criticism of election polling was that 2016 was a disaster, that all our newspapers and outlets that were polling misestimated how close the election was. And so, 538, this was their final poll before the election closed. And this was one of the more favorable summary polls prior to election, people going to the polls, that gave Donald Trump about a 28.6% chance of winning. And, the 538 editors said going into that we should be worried about that. We should think about the margin of error, and how the election was within a margin of error, and there's nothing that's really guaranteed. But how do presidential election polls work? So in a presidential election, 2016, we had about 129 million voters. In general, when people do polls for professional polling outlets or newspaper polling outlets, they might sample 500 to 2,000 people, either nationally or within the state or within certain regions. So to make a prediction about an election outcome, you're only sampling about 1 in 645 voters. And then what happens is those, you call people, you ask them for their voter preference, you might do an online internet survey, and then you use raking procedures. Almost everyone uses raking procedures in how they reweight survey data. And so before you ask them their, in the general election, do you plan on voting for Donald Trump, Hillary Clinton, or a third party candidate, whoever they may be? Before you ask them that question of interest, you usually ask them for their age or their age category, their education level, their race, income, religion, etc. And you project the sample that, the convenient sample you received, you reweigh those observations to represent maybe the state's population, given their breakdown of age, education, race, income, religion. Or you do that for the whole country to get a national polling average. So that's polling science. And so I was actually at an AHA meeting, and Dr. Fonero, my mentor, had a poster about Get With the Guidelines stroke, and it was about some other issue, but we were discussing how there's always concerns about representativeness of Get With the Guidelines data. And I said, well, has anyone tried to just reweight the data, make it more representative, use what we know about the national population to reweigh observations to say this represents the US? And so it was at a poster session at an AHA meeting where I had the idea, and he thought it was a good idea. And so, a conversation led to me doing some investigation in the literature, trying to identify the best methods. And that led to a grant application, and that led to the current project. So what do we understand about stroke surveillance? So how does the US measure how many people have acute strokes, hemorrhagic strokes, et cetera? And so I always like reading the yearly updates from AHA on cardiovascular disease and stroke burden. And when you go into each section, if you look at the stroke section, NHLBI makes those estimates from cohort studies. And And so the Greater Cincinnati, Northern Kentucky Stroke Study has been a long-term funded NIH study with about 5,000 events per year. That one, from mostly the stroke belt, has recruited patients without a history of stroke and followed them using permission to extract data and follow up with patients to quantify the number of events per year. Now on the other side, we have Get With the Guidelines Stroke, which is part of the Get With the Guidelines suite of programs that the American Heart Association sponsors. And the Get With the Guideline program was not meant to be an epidemiologic tool. It was meant to be a quality improvement tool. And so the idea is that let's have hospitals identify cases of, whether if you're in the heart failure registry or ACTION, whatever, let's have them capture cases that are relevant. So let's capture the strokes. And then let's look for various, time to treatment protocols, time to testing, treatment, triage, et cetera. And let's take those, class 1A type interventions and see if we're doing it right. Are we scanning people in a timely fashion? If their patients are early in their stroke presentation, are they candidates for TPA? Are they getting it early? At discharge, are they given, an aspirin, a statin, anticoagulation? Are they being diagnosed with AFib? Are they getting follow-up testing for AFib concerns, et cetera? And so the quality improvement program is voluntary, and hospitals can get, awarded gold, silver, bronze awards for showing that they provide high-level stroke care, that they have systems in place for quality improvement, and that data then comes to Get With the Guidelines and can be used for a lot of researchers use that data for evaluating things like disparities, outcomes, long-term outcomes, effects of policy. And so it's very useful information, but it's not necessarily reflective of US quality of care. And so the great thing about the stroke registry compared to all the other registries is that it already captures approximately 58% of all ischemic strokes in the country. And that's because 2,500 hospitals participate, a lot of them in most urban centers, but also rural participation. And out of about 4,000, 4,500 hospitals, that's a huge proportion. And so every year there's about 250 observations at the patient level. And then, as I said, Get With the Guidelines Stroke is a self-selected sample. It's voluntary. There's no random selection regarding participation. And so post-stratification weights could address a serious problem with the sample. And so the proposal I had said was, well, we can get other data from representative sample surveys, the national inpatient sample, and we can re-weight observations and Get With the Guidelines Stroke to represent the whole country. So for those who don't know, national inpatient sample, a lot of people use this data because it's easily accessible, low cost. It's claims data that's de-identified, but you only get claims data. So you generally get the diagnostic ICD codes, you get ICD procedure codes, you get age, race, ethnicity, insurance status, and you get the cost of care based on what the hospital asked to be billed. So it's the super bill charge. And then there's various methods for correcting that to do cost estimation. So it's predominantly designed, the NIS was predominantly designed for understanding utilization and costs. And it samples 20% of all hospitalizations to be able to get a sample to represent the whole country. And it covers over 97% of all the hospital care in the US based on the sampling strategy, which is a random sample. So here's my theory framework for what we're doing. When you look at the national inpatient sample, for 97% of hospital population. And when we look at Get With the Guidelines stroke, it covers 58% of the population. When we look at NIH stroke cohort studies, there's maybe about 40 to 50,000 patients in those with various methodologic limitations and non-representative samples, but that is generally less than 1% of all the strokes we see in the country. And so what I wanted to do is take these Get With the Guidelines stroke observations and figure out a way to post-stratify them by assigning weights to make them representative of the entire country. And why would I want to do that? This would enhance our ability to understand the epidemiology of clinical factors. We could get timely regional estimates for stroke burden. We can get real-time assessment of regional and national quality of care. And then it also enables us to do high-dimensional modeling accounting for national representativeness. And so we'll kind of go through what we did as a group and what some of our findings were. So raking procedures, as I said, we're getting a small segment of the population. We're cutting out a pie. We don't know where that pie is coming from. And so classic example of weighting, this is polling data. You can look at where people live and looking at the unweighted sample size and proportions. And then for the New York area, reweighting those observations to represent the population of interest, which would be the New York city area. Same thing with age groups. You look at who you sampled by age, and then you reweigh them to represent the known population. Do the same for gender, marital status, race, education, and each observation gets reweighted to represent the population of interest. Now, raking, the way raking works is it's very simple. You set cell counts for these characteristics, and you try to generate weights that that minimize the dispersion of the weights. And so let's say that our population is, we managed to sample 1,000 people, but our true population is 10,000, then our average weight is going to be 10. And so based on the characteristics we've selected, the raking algorithm will try to minimize the spread of each observation to meet the cell count, that's your goal, but to minimize the spread of each weight to be centered around that number 10. And so it's not ideal to take one person and say we're underrepresenting the Bronx. So it doesn't make sense to create a weight that's like 1,000-fold to get that count up to 15.5. Let's try to average everyone in the Bronx and bring their weights up slightly to be able to represent that neighborhood. And so, raking is a lot of fitting linear algebra equations to meet your targeted population counts. So what is Bayesian interpolation? The Bayesian interpolation is basically very similar to what I said for raking, but you're using a Bayesian approach of signals for the various characteristics. So you can have, in this situation, the way we approach it mathematically is that our Get With the Guidelines observations, their weights have a very flat prior. We don't know how well they represent the population we want. And our anchoring characteristics, these are these are the targeted proportions and cell counts. Proportion cell counts are the same. But you end up having multi-dimensional permutations. So if I'm anchoring to whether a hospital is rural, urban, or teaching, whether their age of a patient or race, ethnicity, for each level of a characteristic, those multiply out to become various permutations of each possibility of those characteristics. So if we take someone who's older, African-American, in a rural area, they represent a cell count, and the Bayesian model fits a Bayesian estimate for the weight that goes for that cell count. And so Bayesian interpolation is usually used to, how do you handle noisy data? And so we specify for it the architecture of the dimensions of all the characteristics we care about. And the Bayesian methods will try to fit all that information to limit the spread of the weights. And so it's ultimately very similar, but the Bayesian model has a lot more flexibility to it. And the large advantage that it gives is that you can actually pull in information from another data set. So for this project, we only needed two data sets, get with the guidelines and the national inpatient sample. But maybe there was some characteristic that we knew with greater validity existed in another data set. We could have pulled that into our Bayesian model as a third source of information that is integrated with the information that we're trying to fit and model. And so the same goal exists for the Bayesian model. You want to limit the dispersion of weights, and you want to be able to model the population that you're anchoring to or mimicking, you're mirroring. So again, yeah, the advantages that I just said, Bayesian, you're going to have more flexible modeling capabilities. You can anchor to more than one database if needed. You can also apply advanced modeling. So maybe you can use this framework to say this is now representing the whole US population, but I'm still going to do high-level modeling where I might want to take all the variables in, get with the guidelines, and do a blind, lasso-based feature selection to model some other complex outcome. And it lets you preserve the national weights. And then effect measures. So you can really look at counterfactuals that reflect the population of interest. Just realized I'm really disappointed I had a nice GIF here of an anchor dropping, but I guess I messed up with sharing GIFs, but it's okay. So just to understand the national inpatient design, so the national inpatient sample, the granularity for their survey method allows you to estimate like basic hospitalization epidemiology at the level of 9 US regions. So the weights and survey methods for the national inpatient sample can give you estimates accurately for these 9 regions. It's not just for the whole country. And so beyond this level of granularity, you can't really make population level inference. So looking at our flow of samples for the study, if you look at the national inpatient sample between 2012 and 2014, there was 277,659 acute stroke hospitalizations across 4,780 hospitals. And these are unweighted. And so we basically multiply by 5 because it's on average, because it's a 20% sample to get a weighted estimate. And the weighted estimates are supposed to be accurate, and they come with a confidence interval around those weighted population estimates. Now, get with the guidelines, stroke for the same period of time had far more observations. So the actual raw numbers of observations were higher in Get With the Guidelines. You have 757,048 strokes across 1761 hospitals. We then, sorry. We then had some exclusions based on not having information about hospital ownership, rural status, etc. And so our final sample was 726,390 across 1,500 hospitals. And then we applied either the Raking post-stratification method or the Bayesian, and we wanted to compare them because they're both fairly novel approaches to making a registry nationally representative. All right, anchoring. Oh, I do have GIFs. I forgot where I stuck it. So anchoring. So in order to rake or to do the Bayesian interpolation, you need something to ground your estimates to. And so the best way to do this is to limit the number of characteristics you need to describe the population that you want. And so if you put in too many characteristics, you'll force the algorithms to create too many extreme weights that are unnecessary. And so we tried to be parsimonious in building the post-stratification weights. And so originally we wanted to just focus on hospital characteristics because that makes the application a lot easier. So we know there's a slight skew towards having a more urban, larger hospitals and Get With the Guidelines stroke. And so hopefully our hope was if we just included things like ownership, rural teaching, and bed size, that would be sufficient to get towards a national estimate of reasonable validity. But what we found was in early iterations that we weren't getting good representation out of certain minority groups, primarily Hispanics and Asian Americans. And so we needed to include race ethnicity to get an adequate weighting to represent the national population presenting with stroke. And so we had a combination of hospital characteristics to generate the weights, as well as a patient level characteristics, which was race and ethnicity. But a number of things that I thought we might have needed were not needed. So we didn't need to develop weights based on age. Leaving age alone led to having a very similar age distribution as what we were getting from the national inpatient sample. So a lot of characteristics were not needed, and inclusion of them just would have made the model perform more poorly. So ideally you want I think, a more parsimonious model when you're developing post-stratification weights. So in our results, so exactly to match the national inpatient sample, we had 1,388,296 and 296 acute ischemic strokes during the period of 2012 to 2014. Both our Raking and Bayesian estimates, matched those numbers. And then in general, the clinical data, all the margins to comparing the Bayesian Raking estimates and the NIS were within 5 to 10% of the reference values. And then our interest was to see how extreme were the weights that we were generating. So when you look at the Raking method, and you look at the very extreme weights that are used to make the population estimates, the median weight was 1.366. So that's, a direct multiplication of how many observations there are times how many total strokes we expect for the US during the period of observation. We only have to increase our observations by about 36.6%. But some observations using the Raking of the top percentile, their average weight was 6.881, or at the 99th percentile, with the maximum weight, highest weight for any single observation was 30.775. So it's a very, in our opinion, low dispersion when looking at these methods. And then with the Bayesian weights, very similar. You get 1.329 for the median weight. And then at the 99th percentile, 11 was our weight for those observations in that tiny 1% of the Get With the Guideline observations. And then there was a much higher weight for the maximum, the highest maximum weight for any single observation was 515. So that means there was at least one observation in Get With the Guideline stroke that was multiplied by that weight to help get us to a nationally representative population. And so these are just really two different approaches, and we just wanted to compare how does this flexible, more modern approach to survey post-stratification compare to maybe a traditional approach. And then just to give you, some characteristics of what we did. So this table, we have the Get With the Guideline unweighted data. You see the total counts for the population included. The proportion is represented in mostly percentiles. We have the NIS estimates. Where it says not applicable, that's where the data doesn't even exist in the national inpatient sample. So remember, the whole exercise doesn't need to be done if we had high quality data like from the NIS that included clinical factors or hospital characteristics. So we don't have anything about whether a center is a stroke center, is a primary stroke center, if it's a comprehensive stroke center. We don't know the number of the stroke patients they get per year per hospital. We have no vital signs, no lab measurements, etc. But we can look at some of the anchoring weights. So rural teaching status, you can see that for rural status in the NIS, there was 10.29% were rural. When we use the Raking weights, we hit that number exactly, 10.29, in order to fit the balance that we were aiming for. And Get With the Guidelines, we still kind of in using the Bayesian weights, we still sort of underrepresent that rural population, even though we're trying to amplify that signal. And then we have standardized differences on the far right to see how far off, what's the percent difference between the Raking compared to NIS. So for Raking, in terms of hospital characteristics, there was no difference with regards to rural status. The Bayesian led to a 16% underestimate. And then you see the difference between Raking and Bayesian also has that same 16%, because with the Raking, we were able to hit that. Since it was an anchoring weight, it was much easier to hit with a Raking weight than it was with the Bayesian. And then just looking at some other characteristics, you can look at, there's generally very little difference in making population-wide estimates for blood pressure, BMI, A1C, etc., by applying the weights. And then, I'm missing the other slide, but it's all right. I had another slide with the clinical characteristics. But the main focus was looking at Raking weights. So, and what are we amplifying? And so this is a two-dimensional view, a three-dimensional view of looking at each division, and the lighter the color yellow, you're getting larger weights on average within those. So you can see with Raking that the rural areas, because they're not as represented in the Get With the Guideline registry, that those are the ones that get amplified to bring it up to the national population estimates. Same with the Bayesian, similar thing in terms of average dispersion. In general, the average weights aren't deviating that much. They're not too extreme in order for us to make some population-wide estimates. So limitations, reweighting characteristics selected may ignore populations not captured well and Get With the Guideline stroke. And so there's some characteristics that are really important that neither national inpatient sample or Get With the Guidelines is capturing. And so if they're ignored, we may not be amplifying an important patient population. And then another limitation is that the hospitals that participate in Get With the Guideline stroke they may not be representative of the quality of care of non-sampled hospitals. So it may be that if, it's a quality improvement program, hospitals that choose not to participate, that might be seeing the stroke population that's not included in Get With The Guidelines, are not going to have the same type of quality of care, or might be receiving patients that are much sicker, or not representative of patients that are in the Get With The Guidelines sample. And then measurement error is always an issue. So both with the national inpatient sample and Get With The Guidelines stroke, coding accuracy of things, especially things we're anchoring to, like race, ethnicity, or comorbidities, those might be overcome with this approach. So in conclusion, this was a really exciting project. I've enjoyed it. I think it required a lot of creativity in order for us to solve some problems. It was the first time the Get With The Guidelines registries, to our knowledge, had used any type of Bayesian analysis. We had to use R and some other statistical packages that haven't typically been used for the data. I'm not aware of any patient registry ever using a post-stratification weight approach to model a novel and unique approach to solving an epidemiologic question and improving the validity of observations. The purpose of this work was really to lay the methodologic foundation for future work. Now we've sort of ironed out kinks for how someone might approach this, and use a survey methodology on top of an existing patient registry. We can do more research in the frame that we're really better representing a national population or a regional population, and especially for stroke. And I think when you think about the shortcomings of how we currently do surveillance, these dated NIH cohort studies that are resource intensive with very small samples do not give us good insight into cardiovascular health or stroke health. And a program like Get With The Guidelines is a rich resource that we can better utilize. We have a huge number of observations, 58%. So if you were to have 58% of the electorate's preferences going into a general election, the precision around election forecasting would be so precise. And so I believe that strongly, that this method and applying epidemiologic theory to measurement is going to far exceed the current way we try to quantify stroke burden, clinical data regarding presentation, medications at baseline, medications given inpatient, and discharge disposition. All of that is within Get With The Guidelines. And it's high quality data because it's a conjunction of EHR data, abstracted data, that's high quality. And so the Get With The Guideline methods have been validated by looking at detailed chart review compared to the abstraction forms, and the correlation is very high, where something like the national inpatient sample is passive administrative data that doesn't have that same type of data quality to it. I believe this framework improves our ability to make statistical estimates for a national population. Here we give the example of stroke, but I think it could be applied to other registries where needed. And then it also provides near real-time monitoring of disease burden, quality of care, and outcomes without additional infrastructure and data standardization. So while while we still have a fractured EHR system and you know, even transferring medical information between hospital systems is remains to be a huge task. Building an appropriate surveillance infrastructure is going to be very costly and require an immense data standardization and exchange and security. But leveraging a data set that we already have that's very powerful might help handle those shortcomings for a short period of time. And I'd just like to thank the American Heart Association for funding me. I'd like to thank again the organizers of the finalist competition and presentations. It was a real honor to get to present despite virtually. Did mean I got to dress up, at least my top half. I won't tell you if I'm wearing appropriate pants or not. And then I'd like to thank UCLA for their resources and support with administering this project and accomplishing its goals. DCRI, which houses the Get With the Guidelines data and protects it, and they've just been an outstanding partner. Howland has been my lead statistician who really learned a lot of novel methods and implemented them incredibly. I think she was very excited about some of the tools we were going to be using and overcoming a lot of the hurdles with implementing a model like this. Roland Matsuka is our senior statistician who helped supervise the project and provided really valuable feedback. Ying, who is really knowledgeable about Get With the Guidelines stroke and how to appropriately use the data sets. Yusuf Khan at American Heart, also involved with the guidelines. Lee Schwam and his expertise, Eric Smith, as senior stroke investigators, have been really enthusiastic and supportive of our project and really want to sustain it going forward. And then Dr. Fonero, who's my local mentor and Get With the Guideline mentor, who helped me guide this project immensely. So I thank everyone who contributed. I've really enjoyed this work and hope to get it to press soon. So thank you, and I'll be hopefully taking your questions this weekend.
Good afternoon. Today we'll be talking about the practical application of patient-reported health status measures for those patients undergoing transcatheter valve therapies. I have no significant disclosures. The three main goals of performing transcatheter aortic valve replacement and mitral valve repair is to reduce mortality, reduce hospitalizations, and improve health status in these elderly age patients. Health status involves improvement in quality of life and improvement in functional abilities. Consequently, in 2012, the CMS mandated the routine collection of patient-reported health status in all patients who undergo TAVR and TMVR. Currently, in the United States, this is being done through the STS-ACC-TVT registry, which collects patient-reported health status both before and 30 days after the procedure is done using the Kansas City Cardiomyopathy Questionnaire. Currently, we know that the KCCQ has two main roles to play in these patients. First, it acts as a marker of procedure success. All major partner trials which tested the efficacy for TAVR had KCCQ as an important outcome and showed major improvement in health status by doing the procedure. Similarly, in the recently performed COAPT trial, health status improvement was significantly seen in patients who underwent TMVR. The second role of KCCQ is that it can act as a prognostic measure. An analysis from 2015 showed that KCCQ scores collected just before the procedure was strongly associated with death at 1 year. And similarly, change in KCCQ over 1 month was strongly associated with death and heart failure hospitalizations at 2 years within the COAPT study. Despite these benefits, the real-world use of the KCCQ by physicians is quite low. We believe that this is possibly due to the unclear understanding of its prognostic role when collected both before and after these procedures. And so our aim 1 was to assess the association of health status before and after TAVR or TMVR with subsequent outcomes. Aim 2 was to assess the difference in association by procedure type. We used data from the STS ACC TVT registry, which collects information from about 600 sites across the United States. We included all patients who underwent transfemoral TAVR and TMVR and excluded those who underwent non-transfemoral TAVR as they have a more prolonged course of recovery. All patients not linked to the CMS database or died before 30 days and had missing KCCQ data were excluded from our study. As I already mentioned, health status was measured using the 12-item Kansas City Cardiomyopathy Questionnaire, which ranges from 0 to 100, higher numbers representing better health status. It has an MCID of 5 points, and for this analysis, we only used the overall summary score. Outcomes involved death and heart failure hospitalizations 1 year after the 30-day assessment. For our statistical analysis, we built 5 sequential models. In the first model, we included only the baseline KCCQ scores. In our second model, we included the 30-day KCCQ scores. In the third one, we included both baseline and the 30-day scores. And in the fourth one, we included the change in KCCQ scores over 1 month. And finally, in model 5, we included the change and the 30-day KCCQ scores. In each model, we assessed the association with death using the Cox proportional hazards model and heart failure hospitalization using the Fine and Gray proportional subdistribution hazards model, accounting for death as a competing risk. We accounted for clustering of patients at sites using the robust variance estimates, and the linearity of the association was assessed using the restricted cubic splines. Interaction by procedure type was assessed in each model, and the KCCQ scores are scaled per 5 points throughout our analysis. Our patient cohort consisted of about 73,700 patients, most of them undergoing TAVR with only 8% of them undergoing TMVR. As expected, most of our patients were in the elderly age group, and half our study cohort were of the male gender. About 10% of our patients had chronic lung disease, and according to the STS-PROM mortality risk score, both our TAVR and TMVR patients were in the intermediate range of risk of mortality. Regarding health status, both TAVR and TMVR patients had poor health status to begin with scores in the 40s, but over the course of 30 days after the procedure was complete, there was a significant improvement in health status in both groups. To start off with our interaction analysis by procedure type, we found out that there was no significant interaction both for death and for heart failure hospitalizations between TAVR and TMVR. And so all our subsequent analysis were done using the combined cohort of TAVR plus TMVR. For our primary aim, we found that higher baseline KCCQ scores are strongly associated with reduction of death at 1 year. Similarly, high 30-day KCCQ scores was associated with reduced death at 1 year. When both of these were included in Model 3, the 30-day KCCQ score was found to be more strongly associated with death. Before building Model 4, which is the change in KCCQ scores, we first assessed the linearity of the association. We found a significant nonlinear association at a cutoff point of 25. And so in Model 4, we assessed the association between change in KCCQ scores, both less than 25 points and more than 25 points. We found that change of up to 25 points was strongly associated with death at 1 year, but beyond that, there was no significant impact. At Model 5, when we included both change and 30-day KCCQ scores, the 30-day scores were most importantly prognostic for death at 1 year. These results remained the same even after adjusting for various patient and clinical variables, and also was the same for their second outcome, which was heart failure hospitalization, in which the 30-day KCCQ score was the most prognostic of all the other measures. And similar estimates were seen even after adjusting for various patient and clinical variables. In summary, Using data from the TVT registry, we assess the association of KCCQ scores collected before the procedure and 30 days after the procedure, and change in health status after performing TAVR and TMVR, and found out that the 30-day KCCQ score is more strongly associated with death and heart failure hospitalization. Interestingly, the baseline scores were also independently associated with both death and heart failure hospitalization. Most importantly, there was no difference in the association based on the procedure type. Together with all these results, we can envision a more patient-centered approach to care where health status is used for daily clinical management. For instance, let's consider a patient who presents to the 30-day follow-up clinic after the procedure is done. At this time point, the patient reports his or her 30-day KCCQ score, and this score provides two important pieces of information. One, it talks about the improvement in health status over 30 days. And two, it talks about the health status at that particular time point. The change in KCCQ scores, it represents procedure success. If there was an optimal increase, then the procedure was successful. If there was suboptimal increase, then it's on the onus of the valve team to try and figure out the other reasons for reduction or in suboptimal increase in KCCQ scores. On the other hand, the 30-day KCCQ score, we now know, is strongly associated with death and heart failure hospitalizations at 1 year. And so we believe that this can be used along with other 30-day measures such as echocardiogram or a physical exam to identify patients who are at high risk of developing adverse events and hopefully optimize their care. A few limitations. Most of our study cohort consisted of TAVR patients, this being the more common procedure of the two, but we found that there was no difference in the association by procedure type. Also, most of our patients included those of the intermediate and high-risk aortic stenosis and primary MR, and so association with other groups is unknown. We also did not assess the association with long-term health status. So in conclusion, we found that KCCQ scores, which are patient-reported health status measures, which are measured before and after TAVR and TMVR, are both important for prognosis. Interpretation of the association is the same for TAVR and TMVR, and together we provide a foundational framework for a patient-centered management of severe valvular heart disease, making a strong case for the routine use of KCCQ in daily clinical practice. Finally, I would like to thank my entire team who helped complete this project. Thank you. I would be happy to take any questions.
Hello. Hey, everybody. How are you doing? I hope you're enjoying your day so far, and welcome to our first virtual meeting today. Thank you so much for coming to my presentation. I'm going to talk today about disparities, in particular to cardiovascular disease outcomes here in the US within females and postpartum females. I just wanted to introduce myself initially. My name is Mohamed, one of the internal medicine residents at the Cleveland Clinic in Ohio. Thank you so much for coming to my presentation. So financial disclosures, I have nothing to disclose, and my co-authors as well have no financial relationships to disclose in regards to this presentation. So just to introduce the topic and talk about why our topic is important, here in the US, we've been suffering from an increasing mortality rate, in particular within young pregnant females and postpartum females, that actually is continuing to climb up from 9.8 per 100,000 live birth to 26.4 per 100,000 live birth from 2000 to 2015. And that's in particular a really high rate when we compare the United States rate to the global rate, and also the high socioeconomic status countries and the low countries as well. So that's why this topic is of paramount importance for us here in the United States, especially studying racial disparities within pregnancy outcomes. So cardiovascular morbidity and mortality here in the US in pregnant females is very concerning, and worldwide, it's actually among the top leading causes of death in females between the ages of 20 to 44. In the US here, we have a main goal of eliminating health disparities and achieving equity as a part of Healthy People 2020 initiative. Because of that, we truly think that understanding those disparities, in particular to cardiovascular disease outcomes in pregnancy, can play a significant role in the United States to elevate those disparities and further achieve equity between groups. So what did we do in our study? Our methods and our study population, we selected pregnant and postpartum females hospitalized from January 2007 to December 2017. And we used a larger nationwide database to identify those females. So the mortality and cardiovascular events, or what we call cardiovascular morbidity in this study, and that we defined as acute myocardial infarction events, acute stroke, acute pulmonary embolism, were looked at between pregnant and postpartum females based on race and their race and their ethnicity. Those were the main outcomes we looked at in the study. In addition to that, we looked at the temporal trends of those outcomes. So just to quickly summarize our study findings, first of all, we included a little bit north of 46 million hospitalizations of pregnant and postpartum females. To recap, those are actual hospitalizations or times those females were hospitalized. And we looked at acute events. So some of the females were included 1 or 2 or 3 or more than 3 times. We could track those females. We know the hospital identification, but we actually did not clearly know which females were re-hospitalized again. But that means that we could not exclude anybody from readmission or rehospitalization. So to recap the population that we had in our study, 46% of our population were white, 13.5 were African Americans, and 19.1 were Hispanic. African American and Hispanic females were much younger compared to white females, and 39.9% African Americans and 34.8% Hispanic females were between the ages of 18 and 24 years. Only 25.9% of white females were between those ages. In addition to that, when we look at the socioeconomics and we look at the income of those females, we found that 71.2% of African Americans, as well as 62.3% of Hispanics, were of a lower socioeconomic status, which we defined as below median income for the zip code, which was something that we were provided by the nationwide database. Whereas actually 52.7% of white females were of a higher socioeconomic status. So to recap, white females were mostly older than African American and Hispanic female, and of a higher socioeconomic status and a higher income standards compared to minorities. So the first outcome we looked at the odds ratio of in-hospital mortality, acute MI, pulmonary embolism, and stroke. And we characterize it by gender, by race, and we adjusted for healthcare access. So we adjusted for insurance type. In addition to that, we actually also adjusted for socioeconomic factors. So we adjusted for the income quartile. When we look at that, we see that persistently African American females along our study duration had higher odds of mortality, acute MI, pulmonary embolism, and stroke when compared to white females. When we look at the temporal trends, we actually notice something significant. Yes, there's a significant gap between African Americans and whites, but however, over our study duration from January 2007 to December 2017, we find that the trends of mortality at least was declining along our study duration, even though in the last 3 years of the study, it looked like mostly the mortality trends have plateaued, and that's both in whites and African Americans, and maybe even slightly climbing up in the past 3 years. When we look at acute myocardial infarction, we actually see something that's very concerning over our study duration. So a very persistent gap between African Americans and white females in the United States. However, over the study duration, and in particular since 2012 maybe, or even since 2010, we can see that the numbers have been climbing up rather than declining, and in particular in African American population. Mostly the trends have been stable in white females, and that's something very alarming and concerning in our study. When we look at stroke outcomes, we see that initially stroke outcomes, there's a persistent gap, but then around 2013, 2014, we start seeing that the trends in African Americans are starting to decline, whereas it's also declining in white females, but it's mostly stable during our study duration. And lastly, when we look at pulmonary embolism outcomes, we still see a very persistent gap between African Americans and white females. However, the trends actually appear as if they're increasing over the study duration, something very alarming when combined with acute myocardial infarction. So the increasing trends is actually very alarming in our study duration. Because of that, we went ahead and we did a forecasting predictive model to see how the temporal trends may do in the next few years up to 2025, in order to predict which subgroup will have a higher mortality or cardiovascular morbidity. And we found something very interesting. African American females are projected to continue declining. Their outcomes are projected to continue declining and improving over the next few years. However, Hispanics and Latina women may actually be higher at risk right now at year 2025 when compared to African Americans, as well as Asians and also other minorities may actually be of a higher risk in the next few years. And because of that, we think that more work should go into preventing outcomes or improving outcomes in Latina women and other minorities as well. So in conclusion, we'd like to highlight that very significant racial disparities when we look at cardiovascular mortality and morbidity. Those disparities are very, very alarming, and they're clear and evident. Acute myocardial infarction, also as well as pulmonary embolism, are trending up, and mostly in African Americans, and that's significantly alarming. It's projected that Asians and Pacific Islanders, as well as Hispanics, may actually be most at risk of mortality by 2025 if the current observed trends are continuing to project in the next future or in the near future. Because of our current observations and estimates, we're attempting to provide policymakers with the evidence they need to allocate funds to a specific social and medical programs that can help us reduce those observed disparities and equities between pregnant females in the US. Thank you so much, and we're going to be waiting for questions from the crowd. Thank you.